of the research in our organization. So we are obviously looking forward to collaborations. So now I invite Dr. Agarwal, who is a surgeon, and I would like to request him to speak about that how we can collaborate with a practicing surgeon and what can be the role of AI and machine learning in this aspect. Yeah.
Good afternoon, everyone. I'm Dr. Akhilesh Agarwal. I'm a plastic surgeon. So regarding the collaboration of clinician and statistician, any treatment protocol, as was mentioned by Dr. Kaur Madam, that in current scenario, any chronic disease, we have got a protocol. So how did these protocols come into being? These came after analysis of various confounding factors, variables, and it was detailed, and detailed analysis was done. And that is how we practice medical evidence-based medicine. But how these collaboration can help us, as it is said, any clinician or the healthcare facility, it has got lots and lots of data. But just having a data doesn't help anyone. It needs to be put in together intelligently to come to a conclusion which can help in business, which can help to provide better healthcare facility to the patient and to offload the load on the clinicians. As we were discussing, the use of AI, Madam Kaur's paper of CT scan for the lung nodules, we were discussing how to apply it for the primary centers. As was mentioned, it is really important to have the human touch. If the doctor doesn't touch the patient, patient misses something. So that human touch is important, and it is the basic of doctor-clinician relation, that the moment a clinician touches a patient, a relation is established. So how this can help us? Suppose we are sitting here in Calcutta in the tertiary center, and we want to apply this in a primary center somewhere in an interior. There a doctor who's MBBS, but he's not a specialist. He's working, a patient comes to him. He can get guidance. He can take guidance from the AI that, okay, this kind of CT scan nodule, the nodule which we are getting on a CT scan can be a primary one or benign one or a malignant one. So out there, he can be helped in offloading the load on the tertiary centers by taking care of a primary nodule at the very primary healthcare setup, and where the AI suggests that, yes, it can be malignant, the patient can be sent to a tertiary center. So the load on the tertiary center is reduced. That is one way. Second, as I said, that all the health sectors, they are flooding with data. How a collaboration can help? One is we can establish some research projects wherein we can streamline where the patient should go, how the resources of the hospital can be utilized. That is one. Number two, when we are dealing with a country like India, we don't have a uniform healthcare facility. We have a healthcare facility which is a tertiary center like Medica, where I work, where you have got the best of the facilities, you have got best of the investigations and clinicians, and we have setups like in the interiors, wherein even the basic investigations are not applicable. So a uniform protocol cannot be applied. Any collaboration that needs to be done has to take into account cost factor, which is most important, because majority of our patients, they are not insured, they are paying from their own pockets. Number two, demography. As I said, a primary health center, they don't have the facilities. So the collaboration should be that we filter the patients where a patient who needs basic healthcare facility doesn't have to come to the tertiary center like Calcutta. He can be taken care of in the primary health center itself. A patient who needs an advanced healthcare facility comes here. So that is one way where with this collaboration will help. Number three, the collaboration, if we start any research, a clinician can have a medical thinking, he can have a vision, but to devise a project, a statistician is required. A biostatistician is required from the very inception so that he can guide the whole research in a definitive direction. That will help us to get fundings. That will help in reducing the effort. And streamlined effort will definitely be more productive. Now, the application of AI, especially in surgical line, in my specialty, plastic surgery, there are many apps like face wraps, wherein a patient who's coming for cosmetic surgery, he just wants that, okay, show me what I look like after the surgery, say after a nose job. And this very point has been the bone of contention. It has been the reason where so many litigations are going on across the world, because tissue doesn't behave like maths. It doesn't behave like figures. 2 and 2 can be 5, can be 1. Tissue behavior is different if we talk about individuals like a scar. Indians scar relatively well, but if we are talking, scar is the resultant of any surgery. So Indians fortunately scar very well. But if we are talking to an African person, he is also a human being, but he scars differently. There is always a chance that he can have a keloid or a hypertrophic scar. So we can't promise the same scar to an Indian patient and an African patient based on AI. So here we have to educate our patients that AI can suggest, can give you an idea of what you will look like, what the results can be, but it cannot exactly replicate what is shown on the screen. That is most important. Number 2, post-operative changes, especially when we are talking of cancer reconstructions. Initially, when we do reconstructions, they look amazing. Everybody is so happy. Patient goes for radiotherapy. Once he comes back, the whole results are vastly different. Tissue is shrunk, it becomes black, and that is where one point which AI should take into consideration that, okay, this is one more factor, one more adjuvant therapy that the patient will undergo. So these are few points where, when we are talking of AI into our medical practice, we should take into account. That will reduce the load, that will also reduce the misgivings between the patient and a clinician and the medical legal aspects. Thank you.
So thank you, doctor. So you gave a very good insight that how the load can be, patient load can be offloaded in the primary centers and how it can go back to the tertiary centers in a very channelized way, and also the use of biostatistician in the beginning phase of the project. And again, the most important part of what you told, that how the AI can help in the surgical procedures, specifically for the domain, okay, you are working with. Thanks again. So now I invite Dr. Shubhajyoti Bhomik, who is the Clinical Director of Research of PanelDisc Hospitals, and I will be requesting him to speak upon that how the data is preserved in medical specialty team, and also what are the ethical issues which can be involved in this data storage. Yeah.
Good afternoon, everyone. At the outset, let me thank Professor Chakraborty for inviting me here, and I'm very happy to be in this August gathering where I see stalwarts of AI. So I begin with a disclaimer that I am not an AI expert. I'm still trying to learn bits and bits. But I'm going to actually, talk on one very important issue today, and I have a kind of a live case study to share with you. is Professor Chakraborty mentioned about, this particular workshop is to increase collaboration between the medical professionals on one end and the engineering graduates, or I would say the information technology experts on the other hand. I think the most important thing for this particular collaboration to happen, apart from what my learned panelists have already mentioned, is the awareness about medical ethics. This is extremely important in a country like India, where the landscape of medical ethics is still evolving. What is medical ethics? If I could just highlight for the viewers here, it's something which you think is to be done correctly with the patient data. So the reason I am highlighting this particular aspect is because I am on ethics committees of different hospitals. In fact, at PLS Hospital, Calcutta, where I work, I am the member secretary of the ethics committee, and the researchers, the AI researchers must know that how India has taken a lead in terms of strengthening medical ethics in this country. So the Drug Controller General of India, which is a central government body, actually is institutional in registering all the ethics committee in India. So ladies and gentlemen, let me tell you, India is the only country in the world, and I tell this because I worked at Stanford University School of Medicine for 3 years. Even in the United States, the institutional review boards are not registered. India is the only country in the world which has mandatory registration for the Institutional Ethics Committee. And I urge every AI researcher to know some bit of medical ethics. Professor Chakraborty, I would like to make this humble submission that, we would like to expose the AI researchers to medical ethics. And maybe propose a course on medical ethics for the EI researchers, because I go back to Jhilam, and the reason I mentioned Jhilam and Dr. Kaur is because they connected me to Professor Chakraborty. Because Jhilam and Professor Kaur, Dr. Madhuchanda Kaur, she has been instrumental in driving research at PLS Hospital in the Department of Medical Oncology. And she came up to me and she said that, we have this data of the patients who are doing, the cancer patients who are doing the CT scans. Can we use them for modeling? Is that so easy? Did the patient come to the hospital for giving a predictive modeling tool to the AI researchers? The answer is no, because the patient came to you because you were a treating oncologist, and the patient left back the data in the hospital because the hospital was treating the patient. No way this particular patient has said that this data could be analyzed. And the government rules are very, very strict about it. So what Dr. Kaur did, and she did it very correctly, is she reached the ethics committee of the hospital. And I would urge every particular researcher who's trying to deal with human data, please work with your ethics committee of your respective institutions, because the landscape is not very clear. When I say landscape, the legal landscape. How is it in the world? The European Union has just started work. In 2018, they have proposed the European Union Agency for Robotics and Artificial Intelligence have just proposed what is ethical research in artificial intelligence. Considering that India is India and we are still progressing, we still don't have any data protection bill. The government of India in Lok Sabha will be deliberating the data protection bill this year. And unfortunately, pandemic did not allow this bill to be taken over. So till now, if the patient wants to sue you in the court of law, that why did you use my data for predicting, you have nowhere to go. The legal stand is very pro-patient. So what we need to do is have a very clear-cut understanding of medical ethics, clear-cut understanding when to reach the ethics committee, what to be done with the ethics committee. The collaboration has to come at that level. Because the data might be present in a very structured way, might not be present in a very structured way. Researchers like Dr. Kaur, who want to do it in a structured way will take up a prospective study design. And let me tell you, whenever you go for a prospective study design, informed consent becomes very, very essential. And the ethics committee members look at 4 pillars when you are looking at artificial intelligence-based research. One is beneficence. Is this going to benefit the patients? I would say benefit the human mankind in a larger way. Dr. Power mentioned in her presentation that yes, are we able to predict one particular tumor, lung tumor, in these patients, maybe not in these patient population, but growing prospectively? The answer is yes, this is a beneficial project. So the ethics is going to put a tick mark to that. Does it justify non-maleficence? That means do no harm. Are we doing unnecessarily, are we exposing the patient to CT scans? And we know CT scans are required for these lung tumor patients because as she showed very beautifully that when we need to confirm, we need to do the CT scan and the biopsy. So we are not unnecessarily harming the patient. So the ethics agrees that yes, this is an important aspect of medical research. Does the patient have autonomy? Does the patient has autonomy? That means whether you can opt out of the research. It cannot be just because the data is lying with the hospital and you have a very good rapport with the research director. The director can hand over the data set to you. So they incorporated informed consent. And that is very debatable in retrospective studies. Who will take the informed consent in retrospective studies? These are points of discussion. We don't have an answer right now. And last is justice. That means, are you looking at only those data sets which are easily accessible, or you're looking at data sets which are spread across the population? So if the answer to these 4 important questions is yes, the ethics is the group which is going to allow you to go ahead. Ladies and gentlemen, especially for the AI researchers, please, please, please ensure that these 4 issues are taken care of. One of my previous speakers mentioned about a protocol designing, very important. But the protocol has to be routed through the ethics committee, even if it is a retrospective study design, because the government of India, through the current rules and regulations, particularly I would like to mention the new clinical trial rules in 2019, has clearly made the ethics committees the most powerful body in approving or disapproving research in the country. They are beyond the managing directors of the hospitals, or I would say the dean of the medical colleges. They are independent bodies constituted by both medical and non-medical people. So please, please be aware of this. I'm also going to talk about one other very important issue is telemedicine guidelines in India. So the telemedicine guidelines in India, there is a lot of data being accumulated with the patients on the WhatsApps, because patients are now directly, if I need to consult Professor Pranto Chakraborty, Professor Chakraborty mentioned, send me your report. I get the report, I sent him on WhatsApp. Can I ask Professor Chakraborty, Dr. Chakraborty, can you give me all those reports for 6 months which you've got for anemia, and can I do a predictive modeling? Any other enthusiastic person would say yes, but knowing Professor Chakraborty, I know he's going to say no, because the regulations don't allow. So be very, very careful about the regulations which the government is framing during the pandemic. Ethics is very, very important, but abiding by laws and regulations which the government is framing, and I'm very proud to say that the Indian government is actually doing much more proactive steps during the pandemic than many of the developed countries in the world. So we are the only country which has telemedicine guidelines being rolled out in the month of March 2020, when the entire European Union was thinking about it. So we have marched ahead, much, much ahead than these developed nations. Lastly, being a medical pharmacologist, I would say the collaboration could happen in terms of safe use of medications. This is a very, very important topic by the World Health Organization. I can just make a humble submission before Dr. Chakraborty, because WHO's current aim or current patient safety challenge is medication without harm. It is a very pertinent topic, 40 billion US dollars. 40 billion US dollars worldwide are spent if medication errors are happening. So I call upon the medical researchers, call upon the AI researchers that collaborate with us. We at PLS Hospital will be very, very happy to give you our prescriptions. Of course, with the prior permission from the ethics committee, we would like to work with you for reducing medication errors. And let me tell you that we are the only hospital in the entire Eastern India, and I'm very proud of it, who have published a database of medication errors which happened in our hospital. We had studied 50,000 patients, and we have gone ahead and published their database. At least I give the entire credit to my leadership at the hospital that they allowed us to publish our errors, and we helped so that the others can learn from it. Lastly, I would say that in the COVID era, a lot of drugs have been used: hydroxychloroquine, ivermectin, doxycycline. Let us do some analysis whether these drugs help the patients or not. So that could be another very important collaborative approach between the department and at least the hospital I come from. With this, I would like to end my presentation. Thank you very much for the opportunity once again.
So thank you, Dr. Bhumik, for enlightening us in multiple aspects. Okay, first of all, the need of the ethics in the data and why the AI scientist or technologist should know that, and this should be a part of the curriculum, right? Obviously, we, the university faculty members, will have a serious look on this suggestion of yours. Secondly, pointed out that that how the harmful use of medicines you are trying to focus on, how you are using the data for that. Okay, and lastly, you have given a very good point that how the COVID drugs and their influence on us, on the common people. Okay, so we'll take those issues, and obviously we will feel that we will have a great collaboration with your hospital. So we have now Dr. Pant, and Dr. Pant is a technologist by profession, and he's an entrepreneur. So Dr. Pant is the director, is the founder and chief data scientist of Deep Tech. So now, Dr. Pant, it is now over to you to enlighten us about how the IPs can be generated in the through research in the medical healthcare.
Thank you so much, and I would really like to thank the organizers and Professor Amlan for inviting me over here. And I've been listening to the conference, and one thing which has really struck me, which is very unique about this conference, when I have not seen it happen in many other conferences, is the real closeness of working of technology, data scientists, and the medical professionals working together. And I feel this is absolutely necessary for any success in this particular field. And I really thank the organizers for arranging this. And I'm really sorry I couldn't be there in person, and especially after hearing the conference, I really feel bad that I wish I could have been there. As compared to all of you guys, my experience in healthcare is, I would say, a very narrow and very focused experience. My experience has been using machine learning techniques in the radiology space. So where, obviously looking at the image analytics and, trying to triage different scans like X-rays and CT scans and MRIs, and also, generating reports from whatever has been diagnosed. So this is something which I have worked on with my team for over last 2.5 years or so. And what I have realized is like the gap of getting the algorithm working in a lab versus, getting it adopted by a working professional is very, very large. And many times actually the things which are success factors for a research or research publication versus things which are success factors for something getting adopted in the radiology workflow are two totally different factors. So that is something which I have really learned in last couple of years, and it would be a pleasure to be interacting with you all, to understand more about this and give my perspective about how these things work. As far as the commercialization of the work that we do, which is what like we are a for-profit company, so which is what we are looking for, right? So what I believe that unless we build an algorithm which actually can get easily adopted in the current radiologist's workflow, and it directly benefits one of the stakeholders, it is impossible to make money out of that. And if you cannot make money out of that, then you cannot run a company, based on that. So from that perspective, actually, whenever we are trying to build an algorithm, the first question we ask ourselves is, okay, who is going to pay for it? In the current system, who will use it in their regular workflow, and who is going to pay for it? Obviously, we also do some academic research internally in the company, as well as with academic institutes, as well as some hospitals around us, and we do publish papers. But at the same time, right now, whatever gets published as a paper versus whatever makes money for the company are two totally different factors. And I would really like to discuss more about these things with you. So anyway, I will keep my speech sort of very short, because I'm very interested in doing the panel discussion and doing a Q&A round. So I'll just stop over here, and looking forward to chatting with you all.
So thank you, Dr. Pant, for giving a brief insight that what is happening in the research and what is actually taken up by the practitioners. There is still a big difference, and that difference needs to be bridged up so that the AI researchers can really add a value for the medical practitioners. And now I will go to the floor to the participants, and we will take the questions, and we will just forward it to the panelists and also the experts here. And so we start the question answer session from the participants.
Just a comment.
Yeah.
I congratulate Professor Chakraborty and Subhrajyoti for bringing out one very, very important topic, that is ethics in biological research, which has human participation. Because I have seen astoundingly people using data set of CT scans from machines, Siemens and others. Nobody knows. The human subject doesn't know, the doctor doesn't know, and they are using and selling the data also for research. So data is sold for research without the patients or the participants knowing about it. This is totally unethical. And I'm also a proud Indian like Subhrajyoti, that Indian government has done so much. And we have Prantan, who has been in the DCGI loop, that research should be very ethical. And I'm also a member of the research ethics committee of a hospital, Thakurpukur Cancer Hospital. And we have learned a lot from all the strategies of Government of India. So I'm a proud Indian. I'm a very proud peerlessite also, because here we follow very, very strict ethical considerations, unlike others where DNB research, আমাদের থিসিসটা আজকে চালু করে দিতে হবে, কমিটিতে মিটিংটা কিছু, nobody asks him questions. So that is not the real purpose. The purpose is, in any ethical committee, we have medical person, we have non-medical person, we have social person, we have the legal person. So it's a conglomeration of everybody who learns from the ethics committee and spreads the message to the society. So congratulations, Shubhra. A very, very important topic, and Professor Amlan for giving him this opportunity.
So any questions from the audience? Okay, if you can let us know. Yeah.
I just have a question. What Dr. Agarwal said, on the basis of that, You see the data that comes in, he said that from where he works, the data is very good. And the remote villages, you don't get the same type of data. So when you analyze this data, is it more related to a segment of the population? I mean, the villages, the remote places, these data you don't get. All the research that we do basically is confined to the cities. And the type of problems may be different in the villages as opposed to the cities. So the research that we do basically, can we generalize this? I don't think it's possible to generalize this. So what I feel is that basically the rural sector is outside the purview of most of the research that is conducted here. Is that true? I was just thinking of it.
Sir, I think I will I couldn't express very clearly on that, but I said that all the hospitals and the clinicians have a lot of data, but our health sector in India, it's not a uniform sector. It has got different stratas. When we are talking of a primary health sector, it's and the periphery. So there we don't have those facilities which are available in a tertiary center. So that's what I wanted to say, that whenever we are doing a research, we have to take into account, it's a very big confounding factor that our patients are not same, our health facilities are not same. So whenever we are doing a research, coming up to a conclusion, we have to take into account that our health sector caters to the most underprivileged patients as well as the most affluent ones. So we cannot generalize that way. That is what I wanted. That's what. Yeah. Exactly.
Just to add to what Dr. Agarwal is saying, that, sir, just to answer the question, is it generalizable or not, will also depend on the sample size. So I think if the study under question has adequate sample size, because I would say it will be a nightmare to think that the entire Indian population will be studied, with official figure being 130 crores. So I think Indian government definitely undertakes a lot of research. We have senior public health specialists here from the government. They would be able to enlighten us even much better. But then, yes, it always depends on the sample size. If the sample size is adequate with the help of the biostatistician, then definitely I would say these researches can be generalizable, because they make sure that adequate number of samples from rural India as well as urban India are taken by the governments. But yes, majority of the research which has been funded by the pharmaceutical majors, they tend to happen in the cities because they have better accessibility, better clinician access, better research teams. So those kind of research are definitely under question, because you might not get the entire sample which is existing in the rural database. So the most